So Chintan has muted everyone. We'll be recording the webinar and putting it on our Facebook page. Let me welcome you to the 84th edition. Welcome all of you. We'll be having a teacher of teachers today. Voices speaking, understanding psychiatric illness in the ecological context. So I was trying to make sense of the topic, and I think by the time we end, we'll learn something new. Next slide, please.
Oh, you can, Alim. Chintan, please share the slide of Dr. Avdesh Sharma. We can have 2-minute condolence, then we'll proceed.
Yeah. So we'll have 2 minutes of condolence for Dr. Avdesh Sharma. We have just lost him. Sir, Tufan Pati sir, you would like to say any words for him?
A few words, because there is nothing more to tell about Avdesh. He had been a very good friend of mine since long time. Dr. Avdesh Sharma was the first president of Indian Association of Private Psychiatry, and he has a lot of contribution to IAPP. And he was a leader in spiritual psychiatry or untranscriptional psychiatry all over the world. He was a member of the spiritual psychiatry subsection of WPA, as well as advisor to the spiritual psychiatry subsection of IPS. And he has a lot of contribution. He has conducted many arts of psychiatry seminars in physical mode with a lot of conviction. And I really miss him. And let us have 1 minute condolence for Dr. Avdesh Sharma. And I take privilege to share our deep concern with Sujata and the family members. 1 minute silence. Alim, please keep time.
Yes, sir. Thank you, everyone. So we can proceed now. I'm handing over the session to our chairperson, Dr. Tufan Pati sir. Sir, over to you.
Thank you, Alim, and welcome to this episode of Thursday Musings. We have got a very well-known and very much impressive, and as Alim told, teacher of teachers, Dr. Vivek Benegal with us. And next slide, please. This is a formal introduction of our vibrant moderators, Dr. Amrit Patijoshi and Dr. Alim Siddiqui, who are also well-known to all the audience present over here, both Professor of Psychiatry and members of IPS, quite vibrant and active. Next, please. I have the honor to introduce our chairpersons, Dr. Arul V. Marwale. He is presently officiating the position as chairperson of Professional Liaison Task Force of IPS. He is the incumbent president of IPS Western Jommu branch. He is ex-chairperson of Membership Committee, Indian Psychiatric Society Western Jommu branch, managing committee member of IMA Aurangabad branch, professor, PG and PhD guide of ex-HOD of MGM Medical College and Hospital Aurangabad, MGM Health University. He is a member of Academic Council of MGM Health University, Navi Mumbai. He is a member of Board of Studies Psychology, MGM University, Aurangabad. He is consulting and neuropsychiatrist, Sardar Nursing Home, Samata Nagar, Aurangabad. He is honorary treasurer, Indian Psychiatric Society Social Security Scheme, National Advisory Board member of Indian Association of Private Psychiatrists. He has received many awards. Two of the awards are Rakhmaji Barude Manasastra Award for rank first in MS Psychology, Dr. BM University, 1997. Rashtriya Samman Award from National Education Trust in 2004 and 5. With this, I have the privilege of welcoming Dr. Marwale. Welcome, sir. And our other chairperson is Dr. Nitin Gupta. He joined psychiatry in 1994, young psychiatrist, and have been working as a consultant psychiatrist since 2000. From 2012 to 2019, he worked as professor of psychiatry in Government Medical College and Hospital, Sector 32, GMC 32, Chandigarh, with additional charge of Medical Superintendent, Mental Health Institute, Chandigarh. His areas of interest are psychotherapy, adolescent psychiatry, community and rehabilitation psychiatry, clinical psychopharmacology, and risk management. He has received a number of awards, awarded the Kateria Memorial Gold Medal of PJMR for the best postgraduate student of the institute for the year 1996-97. He is the recipient of over 20 National Journal Conference Awards, and UK, he was the recipient of 5 Clinical Excellence Awards during his tenure in the NHS. His research experience of approximately 240 scientific publications and have co-authored 6 books and textbooks in mental health. Additional expertise, he has extensive experience of being an expert member of the Local Research and Ethics Committee of South Staffordshire from 2004 to 2010. Also held the position of Vice Chair, Latter India, member of the Institute of Research Cell 2018 to 19. Key editorial positions that he has held. He had the editor of Indian Journal of Social Psychiatry. Previously served as 7 years as executive editor of Indian Journal of Social Psychiatry. The editor of Journal of Indian Association of Child and Adolescent Mental Health. Is co-editor of founding co-editor of World Social Psychiatry, associate editor of Drugs and Therapeutics section of the BJ Psychiatric Bulletin, is assistant editor of Indian Journal of Psychiatry, past editor of Indian Association of Biological Psychiatry, past associate editor, Indian Journal of Private Psychiatry, and held many key executive positions at present as also in the past. He has contributed to development of capacity assessment guidance document by the Central Mental Health Authority for Mental Health Care Act 2017. With such a vast experience, we have an expert with us, Dr. Nitin Gupta. Welcome, Dr. Gupta. Welcome, Dr. Marwale. From now onwards, this musings is at your command. Please take over.
Thank you very much, sir. We have the pleasure of conducting the session, and it's a great pleasure to have Dr. Marwale as the chairperson along with me. I have been associated with sir in the Indian Association for Private Psychiatrists, and if Dr. Marwale allows, I don't know whether, is it okay, sir, if I can do the introduction of the speaker, sir, or would you like to do it, sir? Dr. Marwale, sir, is it okay? Shall I do the introduction of the speaker, sir?
Yes, sir. I will go for introductory part first.
Right, sir. Okay, sir.
So let me have that slide. Yeah, am I audible? Nitin, am I audible?
Yes, sir. Yes,
You are audible.
Okay, thank you. At the outset, I thank the organizing committee for inviting me as a chairperson of this today's program. The speaker does not need any formal introduction, but as a part and parcel of any program, I'm going to talk a few words about him. Today's speaker is Dr. Vivek Benegal from NIMHANS, Bangalore. He is Professor of Psychiatry, Center of Addiction Medicine, Department of Psychiatry, NIMHANS, Bangalore. His areas of research interest are: number one is neurodevelopment of vulnerability to externalizing and internalizing disorders. Number two is epidemiology of substance misuse. Number three is translational research, novel interventions in SUDs, and policy and advocacy. The recent work which he has contributed is Consortium on Vulnerability to Externalizing Disorders and Addictions, that is CVEDA, Indian Neurodevelopmental Cohort of 10,000 youngsters. Number two is Acceleration Program for Discovery in the Brain Disorders using Stem Cells, that is ABDS, longitudinal imaging, genetic and stem cell study for the psychiatric disorders. And number 3 is National Mental Health Survey. So in short, he is more interested in adolescent SUD abuse and what happens with the brain of these people. And he has a lot of studies on that. He talked many times in NCIPS also on these topics, and he's very good speaker. So let us hear from him. So should I hand over the mic to Venegal sir? Or Nitin, you want to say?
I'll just say one or two lines, sir.
Okay, sir.
Because when Dr. Aleem Siddiqui was making the introduction, he said something very interesting, and I would like to endorse that. That he tried to make sense of the topic, but could not. He was a bit bemused. The same goes for me. But Dr. Tufan Pati sir, when he contacted me, asking me about chairing the session, I mean, I'm too sort of small in front of Dr. Vivek Benegal to be chairing the session by him. But I agreed for the reason that one, the topic I found to be very, so quote unquote, out of the box, and secondly, obviously, getting a chance to hear him. The topic is voices speaking, understanding psychiatric illnesses in their ecological context. And it's something which we don't get to talk about very often, hear very often, and especially when we are dealing with in our academic system with our postgraduate trainees. This is not something which is routinely discussed. So it's something which is very interesting to discuss and hear about, especially as ecology and anthropology is not something which is routinely taken up in our postgraduate curriculum also. Ecology obviously is something where there is a lot of interaction which occurs between various biological, social, historical factors, looking at how they interact with one's neighborhood and existence amongst the communities, along with one's own existence. We do know broadly that there can be cultural ecology and social ecology and other types of ecology as it has been divided. But the topic which Sir has taken up is trying to understand various mental illnesses in this overall ecological context. So as Dr. Aleem Siddiqui said, I hope to be a bit more wiser by the time the talk finishes, and hopefully we should be having a very interactive discussion. So with these few words, I would like to request sir to start with his presentation. Really looking forward to it. Dr. Vivek Benegal, sir.
Thank you, Dr. Gupta. Thank you, Dr. Marwale. Let me just try and share my screen. Okay. Right. To start with, remembering Avdesh, who has been a friend, and we will certainly miss him, and especially in the context of the talk today, Avdesh really taught us to look at psychiatry in ever expanding context, to look at psychiatry and mental health in the context of the world and in the context of out of the very narrow dimensions that we generally look at psychiatry and the treatment of our patients. So when I talked about this particular topic, and before I begin this talk, let me first say that all blame actually goes to Dr. Tufan Pati. And one of the reasons is that he kept talking, we've been talking several times about what can be done, what needs to be done, how to look at psychiatric issues in a different context. And he was the one who actually egged me on to talk about some of the things that we've been discussing. Although, and I must make it very clear, this is probably not going to be of any use to anybody in their current practice, or something that they can use going home and using it day after tomorrow. What I meant actually in terms of an ecological context was to be able to look at psychiatric disorders, and as they apply in the context of human beings, in the larger context of their world, the larger context of their home and the world. And the reason why I did so was this growing concern that we are slowly becoming more and more specific in the kind of transactions that we have with our patients. We are becoming more and more, the word is not specific, but we are becoming more and more narrow in the focus that we have with our patients. I'll try and expand this idea a little bit more. Suffice it to say, some of the things that I say will excite comment, and I would really love to hear comment from all of you, because this is not really in terms of giving content or talking about data-driven stuff. This is more on the lines that musings. I am going to muse, and in that context, this whole thing of voices. What I actually meant was actually similar to the German word Gedankenlautwort. Anybody who's read Fish is very well aware of Gedankenlautwort, which was a very common psychopathological description of people hearing voices which anticipate what the person is about to think or state what he or she is thinking as she thinks it. And the reason why I said I thought of Gedankenlautwort is because these are unformed thoughts that I have. These are thoughts that I'm actually testing out by talking to people. And in that sense, this is more like one of those Calcutta Addas where we meet in the evening and talk about topics, some of which are probably unfounded, some of which there is a basis. But as we go along in dialogue, we hopefully will be, or at least I hopefully will be able to synthesize my thinking better. But to begin with, the difficulty that I perceive, and this is something that I must say that I perceive, others may or may not perceive it, is that there has been or there have been fundamental changes in the theory and practice of psychiatry over the last 30, 35, 40 years that I have been privileged to be part of. I'm sure others in this in this group have had similar longitudinal experiences. And the question that occurs foremost in my mind, and this is something that a friend of mine, Sanjeev Jain, keeps bringing it up, saying, and he keeps saying that the longitudinal outcome, the long-term outcome of, say, schizophrenia is no better than it was in Kreplin's days. Now, obviously, this is a red herring. This is a red rag to the bull. But the question that I'm really asking tonight is, do our patients really get better? Are they better off than 100 years ago? For example, depression, which is the leading cause of ill health and disability worldwide, has increased drastically and dramatically, more than, say, 18% between 2005 to 2015. And these are the WHO statistics. And I'm sure we've seen it in our lives. Robert Whittaker, interesting in his thoughts, wrote this book called Anatomy of an Epidemic, Magic Bullets, Psychiatric Drugs, and the Astonishing Rise of Mental Illness in America. In this book, he made a cause to look at this trend towards poorer long-term outcomes for persons with major mental disorders as compared to the era before modern psychopharmaceuticals. So I quote from this book, the timing is not coincidental, he says. Modern medications may be a contributing factor to these outcomes, that, worse outcomes, worse long-term outcomes. He says specifically the medications are not very effective. Group outcomes of persons on modern psychotropic medications are minimally and not significantly better than placebo. And more disturbingly, these medications are more than just ineffective, but may result in deleterious outcomes over time. Many current pharmaceuticals may be altering the symptoms, course, and duration of several axis 1 major mental disorders. Now, this is, most of us will object to this, saying, what is the guy talking about? People get better. We see people getting better, and which is, our bread and butter, because we help people get better. And with the pharmacological tools that we have at hand. However, let's look at some of the literature. This is a recent paper, 2020 paper, which came out in Schizophrenia Bulletin, which explored long-term effects of antipsychotic medication following treatment for first episode psychosis. And it found that moderate to high exposure to antipsychotic medication in the long term, and remember, the long term is more than 10 years, was associated with poorer long-term outcomes. The overall findings are in line with previous observational studies, and there are a large number of studies in which long-term maintenance treatment and thus higher exposure to antipsychotics was associated with adverse outcomes. Similarly, there is data, and this is data which actually comes via Tom Insel and the NIH data, which found that in the US, there was a 65% increase in antidepressant use between 1999 and 2014. And this was accompanied by a 33% increase of age-adjusted suicide rate from 1999 through 2017. In fact, Insel went on to say that the 20 billion spent on biological research during his 13 years as NIMH president failed to move the needle in reducing suicide, reducing hospitalizations, or improving recovery for the tens of millions of people who've had mental illness. Now, we can go on in this vein, but I thought I would try and look at some of the reasons why the benefits of acute improvement in our patients often does not translate into long-term benefits for patients. And here I quote from Ross Baldessarini. I'm sure a lot of you would know about Baldessarini. Baldessarini is an expert in bipolar disorders. He's done a lot of work on psychopharmacology, and so this is a prominent psychopharmacologist talking, not some Thomas Zaz kind of person talking. He says that the growing inclination towards increasingly brief and routinized clinical encounters with emphasis on rapid but superficial diagnostic categorization and the initiation of almost exclusively medicinal treatments is what has happened over the last 20 or 30 years. And he again goes on to say that current psychiatric practice has this heavy reliance on medicinal treatment with less emphasis in psychological approaches and on symptom checklists rather than on thoughtful understanding of each patient. So he says that we should actually be reframing tasks and possibilities for academic psychiatry. And what he also says is that this entire process has reframed the task in academic psychiatry and psychiatric research into a greater biomedical perspective. Now, this is one of the problems that a lot of people who trained, say, 20, 30 years back would also have. And when I work with my students, when I work with my younger colleagues, I'm often very surprised if I ask a person, them, does this person have mania? And the younger colleague sometimes turns around and says, sir, I actually haven't rated him on Young's mania scale, so I can't tell you whether he has mania. And you know, most often if I ask somebody, does this guy have ADHD? They'll say, sir, let me first rate him on ASRS. I mean, this is something that one observes day in and day out. And, you know, obviously this has done something to our ability to actually see our patients or our inability to see our patients from these lists. And this is related to the fact that for some time now, we've hitched our wagon to these non-Kraepelinian categorical models, which have formed the ICD and the DSM models. So diagnosis in psychiatry and diagnosis of psychiatric conditions is now established, or is now done by classifying symptoms, complaints, and behaviors based on pre-established criteria. And as early as 1970, Samuel Gouze had exclaimed and said, classification is diagnosis. So if you're able to classify somebody according to this particular list, you've done your diagnosis. Now, disorders, therefore, can be studied. And that this is what we do day in and day out, independently of the particularities of people's lives. It doesn't matter where the person came from. It doesn't matter what the person is doing. It doesn't matter, you know, what happened in the person's life and what are the person's particular difficulties. What is required is merely correct classification in terms of established lists of possibly occurring conditions. Also, in this approach, and this approach occurred because you know, people from the St. Louis school, you know, people who formed the Fairness criteria, etc., wanted to equate psychiatric disorders with medical or disease models, and so symptoms lose all of their underlying meaning, and they have an external validity of their own. The mere presence of a symptom is what is crucial, and its subjective meaning or other qualities are irrelevant. And this is a far cry from the way, say, Bloiler, you know, listed symptoms. This is a far cry from you know, what was meant by phenomenological, when the phenomenological approach was first described. Also, what has happened is the field of psychiatry, according to these Kraepelinian categorical models, is presumed to be made up of discrete disorders that can be distinguished from one another based on some of these criteria. You know, clinical validity based on phenomena, diagnostic criteria, biomarkers, course and outcome, heredity, etc. That's not the point. The point is that we perceive psychiatric disorders to be categorically separate. So when you make a diagnosis of schizophrenia, you cannot make a diagnosis of bipolar disorder. When you make a diagnosis of OCD, it is only OCD if the person does not satisfy criteria for you know, another particular disorder. Unfortunately, in the real world, you know, human suffering, especially mental health problems, do not occur in these convenient bins. And of course, this has led to you know, various other movements in psychiatry, which has, for example, led to you know, trying to look at you know, psychopathology along more along spectra. For example, the RDoC or the high top models have come in, but they actually have not really permeated into regular practice, and definitely not into you know, common thinking. However, in real life, you know, psychiatric co-occurrence, for example, is ubiquitous. You know, 65, and this is data from the Dunedin cohort in New Zealand, which showed that 66, almost 70% of individuals who meet criteria for one disorder meet criteria for a second in their lifetime. And 53% of those meeting two criteria meet criteria for a third disorder, and so on and so forth. So comorbidity is not just limited to disorders in the same domains, internalizing, externalizing, but transcends diagnostic domains, which has now led to a lot of work related to transdiagnostic phenomena. That is, phenomena which are shared across multiple psychiatric you know, categories or you know, domains. What they also found in the Dunedin study was that a large proportion of people, almost 60 to 70% of the people who went on to develop psychiatric disorders later had earlier problems, and most of the problems were probably related to the conduct disorder spectrum. So what they also established, and a lot of these longitudinal studies have been establishing, is that psychiatric disorders often start very early on and continue. However, we are traditionally taught that psychiatric disorders start the time you're able to establish all the criteria, 6 out of 9 criteria. Before that is a tabula rasa. The other problem with psychiatric disorders, the other problem with psychiatric disorders is that unless somebody fulfills 6 out of 9 criteria, the person does not have a disorder, right? In real life, however, a person with 3 criteria can have very severe deficits and disorder. But then again, and this is something that I face with my own younger colleagues who turn around and say, can we treat this person? Because he doesn't have a disorder. He doesn't have an illness. You know, so our current teaching is teaching us that unless a particular person satisfies these arbitrary criteria, the person does not have an illness, does not have suffering, does not have debility, does not have disease, and therefore is not worthy of being treated or having his difficulties looked into. So what I was talking about these transdiagnostic phenomenon, and there has been a lot of work recently which has looked at specific dysfunctions, both in brain structure as well as in brain networks, and definitely shared transdiagnostic psychological deficits across psychiatric disorders. And this one I brought up because this is work which was done in the ADBS study that the chairperson referred to, and where we looked at basically brain networks, resting state networks, and we found that there were certain resting state network deficits which were common to all psychiatric disorders, and which correlated with certain specific psychological deficits, and where which have been correlated with this whole thing of the factor P, common psychological risk, common risk for developing any psychiatric disorder. So the question that I would like to ask people is that we are very happy and we feel accomplished once we have treated a person, say, who comes in with delusions and hallucinations, and we give antipsychotics and the person gets better. But the question that I'm asking today is, so even after antipsychotics have controlled delusions, hallucinations, have we really been able to help the patient? Have we really been able to mitigate the person's problems? Because a huge proportion of difficulties which affect cognitive and emotional capacities remain untreated. So a lot of people who traditionally seem to have been relieved of their major problems continue not to have restored lives. They continue to have deficits and they continue in their disease states, although technically they are cured. And part of this problem is that we have developed a pharmacocentric approach. And the pharmacocentric approach actually arose after the discovery of new psychotropics in the 1950s, gave rise to theories which are now dominant in academic psychiatry, which is why, in a way, Stephen Stahl is one of the most favorite of young psychiatrists. The theory is that the opposite of the drug action is the clue to the pathophysiology. So dopamine excess in psychotic disorders and mania is based on anti-dopaminergic actions of antipsychotics. Similarly, monoamine deficiency became a major theoretical explanation for depression and anxiety disorders, merely based on the 5-HT potentiating actions of antidepressants. Subsequent research at testing these theories at a clinical level or at a neurobiological level have been very inconsistent and unconvincing. However, this pharmacocentric thinking has extended into clinical practice, and it colors our diagnosis and our rationale for treatments which we present to our patients and are couched in concepts from pharmacodynamics. However, a lot of it is little more than neuromythology. Most of your patients will come and say, oh, doctor, so this chemical and that chemical is going wrong, and you will sit in presentation after presentation where you'll be told that dopamine is going haywire here, this one is going haywire there. Now, the ecological, what is the ecological relevance? How do you put it together? Fine, you've got a lot of data for dopamine going haywire there, you've got serotonin going. What is the real picture? What is the larger picture? I mean, imagine, would you expect to discover how the pneumococcus works from the knowledge of the molecular pharmacology of the willow bark or the mechanism of salicylates or aspirin? I mean, that's what we've been trying to do. The belief that psychotropics, routinely provide major clinical benefits, and let me be very clear, I'm not knocking psychotropics. I use psychotropics like every one of you uses psychotropics, and they have great benefits. So I'm not an anti-psychiatrist, nor am I anti pharmacology. I'm just saying that the striking consequence of this widely accepted belief is that it can provide a solution to most clinical problems with the right drug or right combinations. And the compulsion to pursue pharmacological treatments relentlessly, uncritically, often thoughtlessly, is potentially dangerous. So the temptation, given the high rates of partial improvements with monotherapy, is to try combinations higher than recommended doses or add unconventional treatments. Most such practices are responses to patient or clinician frustrations with lack of substantial clinical improvement. What has happened in the meanwhile is that there has been a decline of curiosity. This kind of mono-theoretical basis limits our ability to really solve complex human problems. It is ironic that we have devalued the skills which have been acquired during 2 centuries. For example, descriptive nosologies, psychopathological, psychodynamic understanding of people with illness. And this has lost out to the competition with seemingly simple, effective, supposedly sufficient, cost-effective pharmacological-based treatments. We are strongly encouraged by this pervasive and increasing pressure to produce more units of clinical product per hour, to save as much time and cost as possible, and to avoid asking questions that may seem to complicate understanding or care of a patient. Baldessareni, in this particular paper that I am quoting, goes on to say that the ominous trend in psychiatric clinical practice and in training is the decline of curiosity. We've stopped being curious about other things. We've stopped being curious of the patient's world. We've stopped being curious of what other things and other difficulties that the patient may be suffering. In fact, this is a paper that a long time back, I wish we had published. We didn't publish because it sounded very foolish at that time. But we did this particular study, and we looked at differences between people who got better and people who didn't get better. And we found that one particular factor seemed to come across very strongly, and that was whether the resident in charge knew the name of one member of the patient's family or not. And this seemed to be a fairly significant prognostic factor. I'm just leaving it there. It's not published science, but I'm just leaving it there for your consideration. This is a quote I found, which I found interesting. I've just put it here in the middle. It is the mind which creates the world around us. And even though we stand side by side in the same meadow, my eyes will never see what is beheld by yours. My heart will never stir to the emotions with which yours is touched. And this is very significant because everyone's construction of reality is different from another person's construction of reality. And that is what neurobiology teaches us. And that is what our poets have been telling us. The WPA Lancet Psychiatric Commission which was authored by Dinesh Bhugra and others, goes on to to state this, saying that the untoward effect of enthusiasm about the promises of scientific advances has been the neglect of value of the psychiatric subjective assessment of the patient. And perhaps today I'm trying to advocate to get people to pick up this old habit again, to teach our youngsters about this old habit again. The other reason why we've had a problem with psychiatric disorders is, like I said, they're compartments, and these compartments start when a diagnosis can be made according to these particular lists. But psychiatric disorders do not start de novo, and we know that, as I said in the Dunedin cohort and in other longitudinal studies, that people who are followed up, most people who go on to develop psychiatric disorders have difficulties in multiple emotional and behavioral areas, starting from almost the toddler stage. We know that, for example, schizophrenia originates early in pregnancy, and that probably a lot of the difficulties that occur are already set in during the time neuronal migration is occurring in the second trimester of pregnancy. What we are approaching, and again, I approach from a biological angle, from a neurobiological angle, because I have been doing this kind of work for a long time now, is that the disorders of psychiatry appear more and more, and this is a paradigm shift that is occurring in the science of mental health disorders, is that disorders of psychiatry are probably disorders of neurodevelopmental continuum, and which are sculpted by both the genome and the exposome. So if you start with psychopathology, psychopathology is a disproportionate response or a decompensated response to multiple demands, multiple environment demands, because some people have diminished or altered psychological capacities, or there are people with adequate capacities who have to face supraphysiological demands. So this is a stress diathesis kind of thing. And the difficulties are that there are people who there are individual differences in temperament, coping, skills, learned behaviors, as well as personal narratives, which you can call ego, superego, whatever. Now, why do these differences occur? Because people have altered or inefficient functional brain network capacities, which we are learning more and more, and how they underlie psychological capacities. These different or altered functional brain network capacities occur because there are altered trajectories of neurodevelopment, both program dependent, that is based on the genetic programming that one is born with, or experience dependent, that the brain is sculpted based on the experiences one has in one's life and based on the exposures that one has in one's life. So the environment becomes a very, very major influence on how the brain is sculpted, how brain networks are formed, how psychological capacities are formed, and how one again deals with the environment, which is where the ecological thing comes in. So this is a particular paper, of a very large group, and our CVEDA data is included in this. This is coming out in Nature, I think hopefully in the next week or so, and where we've been able to actually trace some of these brain curves across the lifetime. So these are brain curves of human beings from 0 to 100, and these are brain curves which are constructed on 1.5 million brain scans. But the distinguishing thing about these brain curves is that they seem to also show that deviations from these brain curves, deviations from these trajectories, very critically are connected with risk for psychiatric disorders. Now, why do these deviations occur? And again, this is work from our CVEDA, where we have been plotting the developmental curves of young people, the rate at which people develop or acquire psychological functions. And you find that people who are on lower percentiles, children on lower percentiles, are at much higher risk of developing problems with self-control, negative affect, and other psychological functions, which then put them at disadvantage in dealing with their environment, therefore putting them at greater risk for developing psychopathology. And so on and so forth. I will not spend time. It's already 8:45. Let me go ahead. I talked about these transdiagnostic things, where we are now able to see that apart from core deficits, which are disease-specific signatures, there are transdiagnostic deficits. And the point I'm trying to make here is that we have been trained to look at core disease-specific criteria and treat that. In our treatment strategies, in our we tend to not really give importance to some of these deficits. For example, in schizophrenia, I've already said, one doesn't really bother too much about the cognitive deficits that the person has. We've forgotten about some of these earlier things that people used to talk about, like anhedonia, avolition, apathy, abulia. Our patients still suffer that, but those are no longer targets of our therapeutic action. Our therapeutic action is based very much on the clinical criteria that are there in our categorical systems. Okay, so this was the same thing that was going on. So we have developed newer theoretical models. In the last 20, 30 years, newer theoretical models have developed. And one of the things that we find is that, like I said, this deviations from the neurodevelopmental trajectories seem to lead to altered capacities to deal with your environment, giving rise to psychopathology. Now, why does this happen? This happens because there is a continuous interaction between the genomic inherited genetic programming, which is there to lay down your basic building blocks. And this is shaped into the final product with experience-dependent epigenetic modifications and variable gene expression. So genes are switched on or switched off, depending on what your experience is teaching you. If you go to school, if you have good parenting, certain genes are switched on. If you have, adverse childhood experiences, certain genes are switched off. And therefore, your brain is sculpted in different ways. And there again is the ecological relevance of these factors, because until and unless you deal with these, you are not really going to be able to deal with how your brain grows into disease or into health. And of course, there is the exposome. What we mean by the exposome is external and environmental exposures through the lifetime. Stressors can be psychological, nutritional, neurotoxic, etc. And basically, the exposome consists of external factors like nutrition, neurotoxic factors, physical environment, maternal exposures, infections, psychological exposures like parenting, adversity, socioeconomic discrimination, school, play, socialization. Also, the explanatory models one develops through life. The stories that one learns from your grandmother to create your internal, internal personal narrative. The skills that one develops as one grows. And these also are part of things which keep continually sculpting your brain, changing the way you deal with the environment, and therefore, giving you resilience or vulnerability to psychiatric disorders. And similarly, you have the internal exposome, where you have the gut and other microbiomes, which again help to sculpt your brain, and also the internal things. For example, the default mode network is now known to underlie a lot of the awareness of self. You can call it the soul, ego, self, atma, whatever. But these are things which continuously tend to influence the way people grow into disease or health. And there's a lot of data. For example, this particular slide shows how childhood adversity is an important risk factor for externalizing psychopathology or early substance use in interaction with genetic risk. So on this particular slide, you have adverse childhood experiences on the x-axis and externalizing psychopathology on the y-axis. And as the number of adverse childhood experiences increases, based on whether you have a higher genetic loading or lower genetic loading, your externalizing psychopathology, your chances of having externalizing symptoms in psychopathology increases. And so there is this whole stress diathesis model kind of thing working. I put up this slide because, again, this is data from our CVEDA, which shows the impact of developmental exposure to ambient air pollution and a matrix of environmental risk on cognitive function in adolescents and young adults. So you have effects of BMI, effects of nutrition, and how they affect your general factor of cognition. Socioeconomic status adversely affects cognition. Exposure to PM 2.5, that is to air pollution, very significantly affects cognition as well as brain development. And we are now beginning to develop some of these models where you can see that how genomic risk interacts with adverse experiences, and it changes the way your brain develops to then increase your risk for externalizing and internalizing psychotic disorders. Why am I saying this? Because for example, I just wanted to invoke this developmental origins of health and disease hypothesis, where development is seen as an active process that occurs as a function of continuous dialogue between the individual and its environment, and exposure to an insult during a sensitive period in utero or early postnatal development leads to altered programming or reprogramming of tissue structure and function. And this makes the person predisposed to later behavioral problems, if the person is challenged later in life. So there is an initial insult, which gives you a vulnerability. Later insults, precipitate the vulnerability into actual disorder. Now, this opens up multiple levels of potential engagement. And this is what I really wanted to, and this is not really formed. These are thoughts that I had. And these multiple levels of potential engagement are, we can now start thinking about preemptive interventions versus the palliative interventions that we now do. So early interventions, and people have already started doing experiments in this in the fetal stage, using dietary anti-inflammatory interventions. And for example, in children and adolescents with cognitive control remediation and teaching children skills to see whether eventual vulnerability to or eventual developing of psychiatric disorders can be prevented or delayed. Similarly, it opens up interventions, newer interventions of remediation of network functions and neuroadaptations. Of course, we need to look at newer and more effective pharmacological interventions. People have started looking at nutraceutical interventions, brain stimulation, TDCS, RTMS, again seem to improve the inflammatory, the impact of inflammation on the brain, and seem, again, these are very, very interesting areas which are opening up. Enhancing personal support and skills, effective parenting, teaching people effective parenting, skills training, the effect of school, the effect of play, the effect of creative skills, which have gone out of most of our children's lives because, playgrounds no longer exist. And, art is no longer taught in schools and colleges because, we are no longer bothered in a liberal education, and we want to create technocrats all over. Encouraging socialization, encouraging cultural and community engagements. I'm just bringing this up. We could discuss this if somebody wants. But again, there is data which shows that these have very beneficial effects at a neurobiological level, at the level of how microglia sculpt the brain, how the microglia phagocytose the brain. These have very, very significant effects. So we now need to look at universal, selective, and indicated interventions And this concept of modifiable risk factors is an important thing which is now coming into planning psychiatric treatment. So this is the last section. I will just briefly say what must we do to equip ourselves. A, we need to change our mindset. B, we need to change our practice, change our training, research, as well as our policy, advocacy, and public messaging. How do we expand our mindset? We need to look at psychiatric disorders as disorders on the developmental continuum. Take a movie view rather than a snapshot view. I hazard a guess that we've been all this while, taking a snapshot view of psychiatric disorders and the difficulties of our patients. We need to move away from criterion-based difficulties or move away from criteria ticking to understanding the difficulties and the distress of the patient in the ecological consequences, in the ecological circumstances of the patient. What do I mean by ecological relevance? We need to understand more about the environmental exposure and modifiable risk factors. We again need to go back to understanding the personal meaning and the narratives that people bring, because those color how the person, think about their psychopathology, as well as those are very, very important exposures, which again change how people's brains function. We need to understand more about of people's explanatory models. We need to be able to converse more with our patients about our explanatory models. At one level, we need to resist a pharmacocentric view of the universe without throwing away the baby with the bathwater. Pharmacological interventions are very, very important. Let me, underline that. But it need not be. We need not live in a pharmacocentric world. We need to look at restorative versus palliative symptomatic treatments and to develop collaborative professional networks. Most of the times when I start talking about this, people say, look, where do we have the time to do all this? We don't need to do it. We need to be aware that this needs to be done. So, how does it involve in practice? Teaching developmental history taking. And this is something that we started doing with our students of teaching them to look at history from a developmental perspective. Teaching our students, teaching our young people to be curious of difficulties and distresses outside the criteria fitting, being curious of the personal narratives and exposures across the person's lifetime, learning skills of enhancing people's motivation to change, reframing their narratives, supporting, learning skills about supportive and therapeutic alliance. Teaching oneself about the variety of treatments and therapies available, in addition to pharmacological, which are ecologically relevant based on availability, affordability, and willingness. And the most important thing, and this is something that again we've been losing, is learn to work collaboratively with professionals, helping networks, and with intersecting stakeholders, whether they are parents, teachers, socioeconomic uplift, NGOs, etc., etc. We work back from the best and the costliest available strategies. Normally what we do is, okay, this is a poor person, he won't be able to afford this. Let me give him secondhand care. What we need to do is work back, saying this is the best available. I know that I am not going to be able to do this. I know that I am doing incomplete work, but at least I have thought the best available for this person. Also increasing congruence between what the patient and family want and what one has to offer. And finally, influencing research, directions, advocacy, policy. I'm not going to details, but I've listed some of the things that we really need to do, especially expanding our fields of concern, because mental health now and the demands on mental health are changing, and the COVID pandemic has taught us that, and climate change and changes in society which lead to anomie in our populations is going to actually increase or worsen, psychopathology. So let me end with this slide. One is that, if you look at, we have this concept of psychiatric disorder, which are, different things, different things which exist in the normal state, different psychiatric disorders which exist in a normal, in the real world. However, we understand that a lot of these psychiatric disorders are actually decompensated states, which are a result of stress and psychological capacities. People who have greater psychological capacities can handle greater stress. People who have lesser psychological capacities seem to decompensate at lesser stress. We have always thought about it, at least for the last few years, that these are related to dysfunctions in neurotransmitter systems, etc. We need to be able to actually pull back and see them in the larger context of brain networks. Now, before that, I had this picture that one of the things that also contributes to the stress is the person's personal narrative. And we need to be aware of people's personal narratives, which also color how the person relates to stress, develops psychopathology, etc. So as I said, we need to be able to look at network, and a lot of it is going to be done in research, but we also need to change our way of thinking. We need to realize that a lot of the problems with networks occur because of difficulties or problems which occur in the normal development, and that psychopathology is just a deviation from normal development, and it is not a giraffe to a zebra. But that is the way we deal with it in the real world. We understand that these difficulties in or deviations in development occur because of things which are written down in our genome, but these are also modified very strongly by the exposome, whether it is nutrition, whether it is maternal depression, whether it is parenting, whether it is exposure to neurotoxins in our atmosphere. Which brings me to the larger thing, that ultimately you cannot divorce mental disorders or psychiatric disorders from the larger macrocosm. This is a picture of Mumbai with this major inequity that can be seen from the air, where you have Dharavi slums, cheek by jowl, with the millionaires' bungalows and the millionaire high-rises. And the whole inequity in society, for example, is fueling in very many ways a lot of the psychiatric disorders, and we need to be able to take this kind of viewpoint. I'll stop there because it's already 9, and I don't know whether I've made a good case for what I was trying to say, but I would be happy to take questions, and more important, happy to hear what you have to say.
Sir, you have made an excellent case. It was a spellbinding talk. So thank you so much, sir. Over to chairpersons for their opening remarks, and then we can proceed to the question answers. Please post your queries in the chat box.
Thank you, Alim. Initially, I thought that your sir is going to talk about voices speaking. So really, I thought he is going to talk about the sensory deceptions, particularly hallucinations. May it be normal, may it be caused by environmental factors, and all that. So I was expecting that. So I didn't talk more in the beginning. So anyway, he started right from ANC development, right from beginning. So that's a great thing which was new for me. So psychosis per se starts from womb itself. And as the adversities are faced by a person, so that will precipitate it. So vulnerability is there from beginning, the developmental aspect itself, and later on, when there is stress, the stress diagnosis model may work and cause psychosis, and we will have all the psychiatric, positive as well as negative symptoms. So it was a really wonderful session. I was very much pleased to hear you, sir. Thank you very much.
I think I don't have anything to add at the moment, but think Professor Benegal has reminded us about the importance and the richness of a good psychiatric assessment, which somehow we have forgotten at the moment how about it. But I think it will be more important that we take up the questions at the moment, because there seem to be a lot of questions from the audience. So I'll request the moderators if they can start off with that, please.
Amrit.
It was actually, sir, spellbounding, the presentation from Robert Whittaker to the the slums of Dharvi, the way you weaved a story, with all elements in it, from psychotherapy to the failing of magic bullets to early in utero. So everything is important in psychiatry, and we as clinicians are failing our patients is the thing that we need to reopen our eyes. So we'll take questions first of all. Alim,
Yes.
You start with the first question.
Sir, first my question. You said that schizophrenia is starting from the womb. So would I be correct or incorrect in saying that the foundation is actually laid before the child is conceived? It is in the inheritance that has been planned. So it is actually the foundation is laid before, and the process starts when the child is conceived.
We're really not sure of that. But then one of the things is that, most of these studies have actually come from these brain, these brains in a cell, what are they called? These stem cell things which are made into brain organelles. And so these brain organelles are taken from people with schizophrenia. And so you find that in these brain organelles, when the neurons grow, they grow more haphazardly than the neurons which are taken from people who don't have a history of schizophrenia. So one of the things is that, yes, possibly a lot of this is written down in particular genetic instructions. However, there is also the thing that, there's been a huge amount of literature which shows that mothers suffering viral infections are at much higher risk of having children who go on to develop psychiatric disorders, in fact schizophrenia. So the whole viral theory of schizophrenia was there, which now is again very contextual, because we've been through a stage where a large proportion of our patients, especially mothers who were pregnant at that time, have developed infections with viruses. Viruses cause inflammation. Inflammation causes changes which occur to the genetic message that we have, as well as that inflammation then also causes very significantly the microglia in our brains to chomp away, to modulate and to structure and to sculpt the brain in a different way. Similarly, for example, very recently you must have read things, they've been in newspapers also, that even people who've had very mild COVID infection have had changes in brain structure. It's not entirely coincidental that people who had COVID talked about the brain fag syndrome, that that they're in a fog, they can't think, even with people with mild COVID. So the difficulty is that, and this is my worry, that like it happened after the 1918 flu epidemic, that there was a large number of people who were discovered with a whole lot of behavioral problems. And that it gave rise to the discovery of minimal brain damage, which gave rise to the discovery of ADHD. We are going to see a lot of young people develop problems. Why young people? Older people are developing problems. There is a Lancet study, for example, which talks about the fact that 1 out of 3 people, and this was done on almost 1 million subjects, 1 out of 3 people who've had COVID have brain-related problems, whether coarse brain-related problems or depression, anxiety, etc., etc. So, to come back to your question, I don't know whether it happens before the child is born, but certainly it's part of the developmental process. the good thing is there have been studies which have shown that mothers who are given choline as part of their diet in second and third trimester pregnancy are less likely, or their children are less likely to have some of the cognitive deficits which underlie schizophrenia or underlying or are transdiagnostic for all psychiatric disorders. And so in the same way that there are problems, this kind of findings also lead into doors that we can explore in the future.
So, sir, if the mother is well fed and there is lack of infections, the environment is good, she is happy, then it is a better chance for the child.
Absolutely, absolutely. That is exactly what we are saying. So if you have to do anything about psychiatric disorders, start with the mother and the child. So the most important people in the next 50, 60, 50, 100 years are the people in maternal and child health.
Okay.
And us, of course. We need to do it in our day-to-day, in our houses as well.
Sure.
Sir, we have Dr. Dushadram from all the way from, sir, kahan se hain abhi? Qatar.
Saudi Arabia. Saudi Arabia.
He wants to ask a question. He has raised his hands.
Sure.
Sir, I would like to thank you for your extraordinary presentation that enlightened us, particularly for new generation. Sir, I was just doing, in collaboration with NIMHAS, we are coming up with some prevalence studies. I am in Saudi Arabia, and they have done a prevalence study here. They found that 30% of the population are mentally ill. This is most conservative data. They are expecting it may be crossing 40%. So how you explain this in terms of ecological aspects, sir?
See, one of the things is that it's not, I didn't understand. How is the prevalence related to the ecological aspect? By ecological, I mean that mental disorders do not occur de novo, out of the blue. Mental disorders occur because of various things that happen during development and which are in the environment, which are part of the exposome, which are part of psychological stressors, nutritional stressors, etc. So mental disorders will happen in all societies. The issue is that we as psychiatrists need to be able to understand this in the context of the ecology, or in the context of the world that the person lives in. And we had felt as biological psychiatrists, or we had felt as pharmacocentric psychiatrists, that we don't need to do that anymore. I am saying that we need to go back to older ways of understanding, because whatever you do, you give antipsychotics to your patient, right? Everything gets better, but the person also needs to learn what has happened, needs to be able to put it in the context of his or her own life, needs to put it in the context of what he or she has done, or what he or she can do in terms of job, what the kind of effect he or she has had in terms of family and the community, etc. So these are the larger ecological spaces which are very important to how psychiatric disorders are formed, as well as how they are perceived. And without looking at this, you cannot think of treatment. Your treatment is incomplete. That is the point I was trying to make.
Thank you, sir. There's been a lot of debate among the newer psychiatrists. Newer means Alim's age psychiatrists, where they are debunking the whole biopsychosocial model.
Right.
And lots of chats in groups, lots of views on the the biopsychosocial model is now defunct. It should be the biological model with a little bit of like Achar and Papad is psychology and sociology. But with your presentation, I think you have again rekindled that.
In a way, I agree. In a way, Amrita, I agree, because what is psychological or sociological? Everything attacks through the brain, no?
Sir.
Whether you are giving ECT, or whether TMS, or whether you're giving psychotherapy, everything is making changes to the structure and function of your brain. There's enough data. So in that sense, psychotherapy is biological too. However, to say that this is papada chutney is absolutely wrong. Because, and I'll tell you why it's absolutely wrong. We cannot go to the extent, we are dealing with the mind. We cannot go to the extent of telling people ki, "Arey yaar, ye scanner mein ghus jao. After that, I will give you these tablets, you go." People have to make sense of their world. Human beings have to make sense of their world, and a lot of our discomfort comes because there is incongruence between what we want to be and what we are.
Sir,
Yes, sir.
another question that people ask is, there is no mind. You talked about mind now, because these are the questions, 2-3 questions that have been a constant source of debate nowadays, sir. The whole concept of mind. So what is your take on that, sir? And then I'll give it to Alim.
This goes back to this ancient argument of the mind and body dichotomy. Ki mind aur kuch hai, body aur kuch hai. You know, and mind is something which you know, exists outside. The mind is created by all the circuits in your brain firing together to create constructs. So how is the mind created? When you're born with some circuits, some you know, some organs. Organ is to for sight or hearing or for taste, etc. These are written in your genes. It will happen unless you do something really crazy about it. But then you associate with the world. You put your mother's breast into your mouth, and you get the warm milk. You get, and your idea of, you know, outer space, inner space is slowly formed. You fall down, get hurt. Your exteroceptive, interoceptive things help these circuits make a construction of your world, which is why I wrote that particular thing from Griffin. Your construction of your world is very different from my construction of my world. And this is established science. This is not pseudo babble. The way you are actually seeing green is very different from the way I see green. The way you taste sweet is very, very different from the way I, you know, because this is dependent on the inner world that we have created. Or DMN bolo, whatever you say. But mind and brain are intimately linked. And at least that is what our current science is pointing to. So you can't discount mind.
Thank you, sir.
Yeah, so there is a question in the chat box. I think you have already answered it. Any of the experiences are actually changing the brain. So what do you expect of this closure of schools for approximately 2 years? Are we looking at a ticking time bomb?
Yeah,
in the children?
Sudhir. This is Sudhir. And in fact, I have noted it down that, you know, that needs to be answered. Yes, it is a ticking time bomb. Yes, you know, I mean, all throughout the pandemic, outside my house, I've seen these kids not going to school and on cycles going all over the place. I'm worried that they're going to dash into my car. And I've kept joking to my wife that, you know, or kuch ho na ho, at least one cycle champion will come in the Olympics next time from India. But, you know, jokes apart, can you imagine 2 years of school dropped? And see, this is again one of the things, for example, we found in our data from the CVEDA, that even if you had bad parenting, if you had bad genes, if you had you know, some bad environment, your chances of getting externalizing or internalizing disorders was more. But if you had all these, but you had good schooling, for example, that could mitigate the effects of all the other developmental influences. So yes, some of these are highly protective things, and if our children have not been able to avail of these, it is going to cause a problem. So the loss of, for example, playgrounds is causing a problem. The loss of having another child to bash up and learning pain, learning empathy through that is creating hordes of young people who think nothing about shoving an iron rod up somebody's vagina. Because these are people who have never learned what it is to hurt somebody or get hurt. So that construct in the mind has not been created. Those networks have not been created. And yes, this is exactly what I meant by, you know, trying to look at things in an ecological context.
Okay. I think Arun sir has a question.
I can't see it. Can you just read it out?
Shall we read it, sir?
Yeah, you can read it. Please read it.
Sir, it is said that auditory verbal hallucinations are initiated due to temporal lobe neuronal hyperactivity, which is not inhibited by frontal lobe activation. Your comments, please, as regards to what happens to default network there and other networks also.
Okay, so this is very specific, and this is outside my comfort zone. I can't be. I don't think I can be this specific, but it is also true that a lot of these things, delusions, hallucinations, etc., are related to altered network functioning that occurs, and which is related to some of the things that Dr. Arun has talked about. But I cannot be this specific because I honestly don't know enough.
Okay, so there is a question: how do we practically implement this developmental perspective in management of our patients, especially in the patients who have externalizing spectra to start with, in the background of trauma, and currently present to us with significant personality issues, particularly ASPD and BPD and substance?
Okay, so this is something that it's particularly dear to my heart, because this is something that we do day in and day out. And one of the things is, of course, to inform oneself, to actually, like I said, change mindsets and realize that these are a longitudinal thing. So people, for example, who have addiction or antisocial personality, etc., or have had difficulties, and mainly difficulties in the area of cognitive control, in the area of emotional regulation, and of emotional recognition, theory of mind, empathy, etc. And these are things which they have had from childhood. So number one, you need to take a good developmental history. Most of our the most irritating thing that happens when somebody is presenting a case to me is the uneventful childhood, or the person was an easy child. Everybody borrows from Thomas and Chess. Person was an easy child. People, I mean, let me be, of course, being a little provocative. People who are easy children don't go on later to develop problems unless something really bad happens in between. Most of the people, and this is a lesson that we've learned from most of the longitudinal studies, most of the longitudinal cohorts, about 70 to 80% of people who get on to develop psychiatric disorders, any psychiatric disorder, schizophrenia, anxiety, OCD, had problems in childhood, if their mothers remembered. And so this is something that is very important to remember, number one. Number two is, of course, people who have had already developed these problems, you really need to look at it in this context, that these are people who have difficulties. I mean, for example, you need to understand that the person who's lying is doing so because he or she is highly impulsive, not thinking of the context, is in a difficulty, blurts out something. And whether you see it as somebody who's having difficulties with impulsivity, or you see it as a person who's lying and therefore a very bad person, will color the way, will color your therapeutic stance. And this again is published work. There's enough work to show that the kind of therapeutic label you give somebody is likely to color your therapeutic stance, and also to influence whether your patient gets better or not. That is number one. Number two is, and this is something that accidentally Dr. Tufanpati has come on screen. This is something we've been discussing for a long time, that we seriously need to start talking about getting mental health interventions into schools. We need to start talking about getting parenting information to parents. We need to actually start getting information about diet, good diet, play, creative work, etc., to schools and to parents, as well as part of our intervention that we do with policy. We need to tell policymakers who talk about this. For example, I mean, I'm not advocating vegetarian, non-vegetarianism, but getting eggs out of the school menu for the people who will eat eggs, or getting things which give you choline out of the school menu is such a ridiculously stupid, idiotic thing. I can't tell you, because this is the choline. You take choline out of children's diets, you are increasing chances that they will have a whole host of psychiatric disorders. Okay, don't give it in egg, give it in some other fashion. Not giving children playgrounds to play is such an idiotic, stupid, thing to do. Getting children to play with tablets from the time they are 2 years old is such an idiotic thing. I'm sorry, I actually want to use even more dirty language, but I can't do it here. But net, I don't know whether that answers your question or I went off on a tangent.
So you answered a question already in the chat box.
Yeah.
That we need a mental hygiene movement in India. We don't have it. And they were asking for suggestions of family, community, and social initiatives. So I think you already answered that.
Yeah, so I can't go into details right now. And honestly, I don't know all the answers, because that is why I thought, I would discuss with all of you so that, together we can change.
Yes, sir. One question on neuromythology, if I may say, this medications that we give. Suppose SSRI, this acts on the serotonin level in the cleft. So is it the primary action, or it is then the molecular action then that is changing the brain? Because won't this be homeostatic mechanism will down regulate again the things?
Yeah, so it is not just 5-HT, no? When you talk of homeostasis, remember you're talking of a network. If you take any net, you go and look at the mosquito net in your house. You pull one part, the rest also get perturbed. So what Baldassarin is talking of is not to discount pharmacological treatments. It is to say that the explanations are so simplistic, and the way that we use it is so simplistic that it and the way that we use it is not simplistic, is total carpet bombing, that we don't allow the possibilities of other interventions, which would also be very helpful.
Okay. Amrit?
Yes. There's few questions. Should we take more questions? All the questions, or
Benegal, sir.
Benegal,
I am
sir,
fine.
are you support for
how
how
long
many
you
more
want
minutes?
to? I'm absolutely fine. I like to talk, but you guys decide how long you want to prolong it.
Because we want to have Benegal sir again. So
that is a different issue. I will get even more vague.
So there's a question that always comes. And how important would you rate meditation and mindfulness for patients who are able to do this?
See, again, this is a loaded question, right? Because meditation, mindfulness, yoga, everybody says, first of all, we need to really examine very well how these things work. But I have, at one level, I have no doubt that these work. But we really need to subject it to proper scientific scrutiny, and that is something that I must say. But having said that, ultimately, what are you doing with meditation, or with yoga, or with tai chi, or with reciting prayers? You are actually changing, and there is some data for that. You are changing brain networks. I mean, mindfulness. There's been quite a lot of work with this group in Colombia, who've been working with the Dalai Lama and this Rinpoche, I forget. They've got quite a lot of published work.
Another question is, environmental influences, especially in Indian culture, persist for a very long time. How does that work out? Since dysfunctional family dynamics will persist and maintain behavioral reactions. So can anybody overcome all these things, and how does it actually work out to be?
Yeah, so I mean, you can overcome it. It is difficult because if it is something that has gone into shaping your brain, and we know when we talk of shaping the brain, we are no longer talking just figuratively. It actually physically shapes your brain. But remember, that your brain is being shaped continuously. So if you find a good mentor, if you find, other good developmental things to help you, they help. I mean, for example, a long time back, we published this paper where we looked at children of alcoholics, and generally children of alcoholics do very badly. But we found that if children of alcoholics had one other member, aunt or uncle, who took on the primary rearing roles, they managed to do very well. So it's not something which is written on the forehead. You can always change it. The brain is malleable, the brain is labile, but all the more we need to understand the ecological construct, the ecological, how do I say, the ecological influences, because the ecological influences are the ones which will really help us rechange our brains.
Okay.
Philip John is saying something.
Yes, sir. Dr. Philip John, please unmute.
Yeah, I'm audible.
Yes,
Yes.
sir.
Vivek, excellent presentation. I'm glad I quit my OP early and came to listen to this. What I wanted to talk about, reflect on your whole presentation, is that this is not about any non-medicalization of psychiatry. This is certainly about medicalization of psychiatry, but understanding, incorporating the exposome into the developmental factors, which will actually ultimately determine whether the individual goes into any psychiatric morbidity or not.
That's right.
Therefore, I have a problem. My problem is that there is a non-medicalization of psychiatry in terms of the diagnosis, because unfortunately we have moved on to from a dimensional model which we should have been going to, instead into a categorical model more and more. But then there is a tendency among junior psychiatrists, even people who come out from NIMANS, as you rightly said, let us look at this inventory, let us look at this questionnaire, let us look at this rating scale, and therefore make a diagnosis. It is actually terrible. You are a teaching institution, and that teaching institution, I think, should take lead in making people understand across this country that making a diagnosis of autism is not based actually on getting an MRI done or getting a rating scale done. It happens in your head just as you would make a diagnosis of OCD. I don't understand why developmental disorders especially have to be dependent on, especially like the pediatricians and the neurologists, have to be dependent on the psychologists who are not, I don't think of that as science at all. I don't know why they are being depended on for a diagnosis. It is a very tragic thing that is happening to the medical specialty of psychiatry. Your comments.
Philip, you know the problem. The problem is that we have taken RCTs as our gold standard. A lot of these have come from RCTs. And of course, in RCTs, you need to do that. You need to look at instruments, etc. But then, because RCTs have become our gold standard, number one, we really don't look at what happens to treatments in the real world. We don't look at it naturalistically. Now, that is number one. In the same way, we have taught ourselves, and of course, our younger colleagues are probably more guilty of that. We have taught ourselves that this is the way to do psychiatry. This is the way to be a good clinician. By the more objective you get, the better clinician you are. And unfortunately, and that is where I said, this is the loss of imagination. This is the loss of the ability to suffer these fuzzy boundaries. We more and more we want things which are very specific. We want things which are tied down, and the ability to suffer grays has come down. The ability to understand grays has come down, and which is probably, and I'll say probably, which is probably not a good thing to have in a profession like ours, where most of our people live in grays.
Okay. Sir, just one very, very quick query. How much genome and how much exposome? What is the range?
Again, it depends. See, for example, this is work which has happened in the last 1 year. There is one lovely paper in Nature which has used humongous amount of data to look at which are the genes which are used in growing a brain. And most of these, unfortunately, are things which are related to cortical thickness, surface area, and things like that. So a lot of the genetic influence is on things which are on the hardware, on creating the hardware. And a lot of the things which are related to you're using the hardware in your day-to-day functioning are things which are more labile and which are getting tuned by the environment. So if you live in Saudi Arabia, your brain is going to function in a slightly different way because it has been attuned to living in the heat. Whereas if you live with the Inuit in Greenland, your brain is tuned in another way. And for that matter, the Inuit have some 200 words for snow and white. Whereas I'm sure even in our language, a person in the Sahara Desert will not have any words for snow or white in that context. So a lot of the brain which is used for your day-to-day interactions with your world are very labile, and therefore the exposome every day in every way keeps modulating it, keeps moderating the brain.
Sure. So we should try to keep up the exposome as better as possible because genome
absolutely, and which is the worry, that with climate change, with changes in the way we perceive our society, the way we are not able to we become monotonous in the way we perceive what we want. We are not able to appreciate diversity. These are all very harmful in the long run.
Okay. Amrit, we have covered all the questions?
No, we have covered almost all the questions. It's difficult to cover because every answer brings up another question. So, so I think we should end this session. We should hand over the mic to the chairpersons to give their concluding remarks.
And then Tufan Pati, sir.
And Tufan Pati, he is responsible. He has to give the final comment on
But
this.
wonderful, sir. Sir.
Wonderful, sir. Really wonderful. The chairpersons, please. Your concluding remarks.
It was really wonderful session. I'm very much pleased to listen to Benegal sir as well as the question answer session. So that's all from my side. Thank you.
I think I echo what Dr. Marwale said, and think very important messages which have come out from the presentation by Dr. Benegal, that it's very important not only to adopt a holistic view while conducting an assessment of the person, but also to look at the individual and just not at the symptoms which the individual is presenting with, but also to look beyond the person and also around the person, so that one can understand the context in which these symptoms they are occurring. And I think it was beautifully summarized in the end, which I hope that as a take-home message we all can learn from. And thank you once again to him for this excellent presentation, and I would like to thank again Dr. Tufan Pati, Dr. Siddiqui, and Dr. Amrit for giving me this opportunity. With this, I hand over to Dr. Tufan Pati for his concluding remarks, please.
Thank you, everybody. First of all, I profusely thank my dear friend, Dr. Vivek Benegal, for this fantastic erudite lecture. And this, he told that if there is anything wrong, Tufan Pati is to be blamed. I very well knew that I am not going to be blamed, but may I share the accolades being given to Dr. Vivek Benegal? Now,
Definitely, sir.
When we eventually discuss about certain issues and go beyond the boundaries of normal teachings, one thing what is important is that when we go to address to the needs of a patient, I am intentionally avoiding the word treating. One has to understand and identify the health needs and problems of the person. It is not merely treatment. And when we think of health needs, if we accept the definition of physical, mental, psychological, and social, spiritual well-being, what we are prompted to believe is that physical is a part, which comprises of the signs, symptoms, suffer in the checklist, rating scales, biological parameters, pharmacology, this is one part, on all other psychosocial aspects of the other part, which are not based on science. But that is not a fact. First of all, we have to believe that they are interrelated and both are equally scientific and based on biological psychiatry and based in the brain. And this equation of genomes and exosomes, if you understand, we are convinced in our understanding where we make a construct of the patient as we see, this must occur to our mind. We are not going to just write by the ticking the scoring sheets given to us. We have to understand the patient holistically and integrally. And what I have always been advocating, if you have to safeguard the future of mankind, all the healths are related to each other. One has to focus on parenting, bringing of children, not in the schools as well as outside, and maintenance of the environment. These three things are essential if we are trying to think, and if you can see that the generations to come after 50 years are not in a big danger. And Dr. Benegal's deliberation has, at least, I think everyone should believe that these are not apart. Meditation, psychological, they are based in the exposomes. We have to see that exposomes do not have deleterious effects. This is the message which I take, and I think I shall share with many. And with again profuse thanks to Dr. Vivek Benegal, who has kept my request and come. Maybe I shall request him again. Thank you very much. And I am not taking any accolade from you because it is all that you deserve.
No. You are 80% to blame. You are 80% responsible for this, because remember we talked about this over several talks on the phone. So you can't get out of it so easily.
So with this, I hand over to Dr. Amit Patujoshi for formal vote of thanks on behalf of ITS Odisha State Bench.
Thank you. Thank you, Vivek, sir. It was actually an enchanting experience hearing you. And the best part about Dr. Benegal, sir, was, I had always heard of Dr. Benegal. First time we invited him on Zoom for this Thursday musings, and the sir was wearing a mask. I could not recognize sir, but sir came and told me, "Hi, Amrit, how are you?" I was shocked. So for us, it's a big experience. Somebody like Dr. Benegal coming over to you and recognizing. I think the whole virtual platform has given us a chance to interact and to know more about all the stalwarts of psychiatry. So having a stalwart today was itself an experience, and the topic you chose and the way you went about it, I think that is another learning experience from you. The theory part is one part, but the way you did the whole thing in 30-35 minutes from 0 to next 100, it was, and we could not know where we are going, and we landed from biopsychosocial to biology. That was a very wonderful journey, sir. Thank you so much. Thank you so much to Arun sir, always the humble man. Is always the great man. Nitin sir, slow, sure, but absolutely confident for the way you handled such a nice topic. Thank you to Dr. Tufan sir for engaging Dr. Benegal over phone and getting the best out of a person who is considered the best. So that's quite an achievement. Thank you, Alim, for allowing me to ask certain questions. He generally does not allow me to ask questions. We again had a full house. more than 200 participants, 250 or 260 participants with a peak of 205. And that's wonderful when everything is opened up, people are busy in their clinical practice. And that speaks a lot about the quality of the presentation, the quality of the speaker, the quality of the faculty, and the quality of Thursday musings, in spite of all the criticism we get. And thank you to all our, audience who unfailingly log in. Thank you, Torrent. Thank you, IPS Odisha State Branch, for allowing us and giving us a free hand to do the work which we are doing with a free hand. Thank you so much. Good night. Next time we will have another speaker. Hope you.
Thank you. Good night.
Good afternoon.
We'll be interacting. I shall be back to you, Dr. Vivek Panigal, within 2 days.
Thank you so much.
Thank you so much, sir. Wonderful. Really wonderful.
Because that program of mine is pending.
Good night, sir.
Thank you.
Good night.
Good night.
So, bye. Good night.
Good night, sir.
Enjoy, everybody.
Then we can close the meeting now.
Okay, sir. Okay.